Hello, welcome back, and hopefully this will be a much more succinct, as I always say, and hopefully more coherent delve into the world of pandemic modelling. And we're going to be finishing up the report 9 of Imperial College on COVID-19, on the coronavirus, novel coronavirus 2, SARS-CoV-2. And we are going to be recapping what we've covered last time in a much more succinct form, finishing off a discussion, and perhaps rounding off with a few points before we discuss potentially where we might go next for the next set of modelling. So without further ado, we will go through our summary. The first thing I think I need to say is, we need to recap how the model actually works. The model is an individual level simulation with an artificial population based on UK demographics. So they basically created an artificial UK with an artificial UK population and an artificial set of geographical regions with an artificial set of people in them, artificial workplaces, artificial homes, artificial clusters of homes, people you know, so on and so on. And they created this miniature version and populated it with entities, and this entity is little more than an ID number, and it doesn't relate to an actual person. It's a hypothetical person that's been generated based on statistical data. A list of where they are, how much time they spend in different places, age, statistics about demographics, that sort of thing. And they run a simulation on that file, that ID number, and indeed on the 66 million files that represent the population of the UK, and see what actually happens to them. Right. So the individuals are all assigned locations, homes, the homes of people they might know and might visit, their workplace, their community, which encapsulates a lot. That encapsulates recreation, shopping, just bumping into someone in the street, and then there's kind of schools/universities, which are also based upon data, and quite a lot of this is in the public domain. So I assume, well, we'll get to the data and where they acquired the data in a minute. And basically they assume that they split their time between these different areas and different locations. And the thing that concerns me is that they didn't seem, at least as far as I can tell based on the report, to include social care housing as a distinct location, which is concerning because rather like schools, it's both a workplace and a residence, but it's a large communal, they are typically large communal residences, which gives them a very different flavour, a very different feel in terms of the way pandemics and diseases can spread through them. That is really something I would have liked to have seen included. And it's certainly something, given that we now see quite a lot of cases in care homes, that perhaps people wish had been included. But it wasn't, as far as I can see. And of course, the assumption is that you can only transmit the disease if you happen to be in the same location as somebody else, and that transmission probability is calculated based on a load of different factors like the location, your age, their age, other various statistical information like that. And you have a random chance based on that probability of passing the disease on in any given moment of time that the computer simulates. And these sort of simulations, they might sound massive, trying to recreate the entire country, but I believe it only used something like, was it 55 gigabytes or something, I'm sure I read somewhere, and that's really not that much in terms of really large academic modelling simulations these days. So yeah, and only 8 processors, so there's a lot more computing power available and a lot more hardware available to bring to bear on this sort of thing, if it is I was there for a more complex model. So, the parameter sources. for the parameter sources for the information. So obviously the information about the population, work, home, school, that was generated from census data, and they didn't actually disclose what other data sources they used, but they talked about known data sources. So I'm assuming that's probably government statistics. A lot of the parameters about this disease have been extracted from early clinical studies on the SARS-CoV-2 virus, and also from epidemiology data. Some things have been transferred from influenza, but they're not wholly unreasonable things. I think it's mostly in relation to population contact studies and that sort of thing, which you would imagine probably wouldn't change simply because the virus has changed, but of course people's behavior can change in a pandemic, so that's a factor. And one that the authors acknowledge repeatedly. One thing that was concerning is that the prevalence of asymptomatic cases is something that's fairly highly disputed. Yeah, it's quite a big issue. That particular issue is hot right now. I think there's really much consensus based on what I've read recently on what the proportion of asymptomatic cases is, and if you look at the literature as a whole, there's variation from like 1% to 99%. And given that that's the case, it would have been nice to have some sensitivity analysis on that figure. That is to say, running the model several different times with several different figures. So since there are so many other figures from literature, so many other figures from in the literature about what the rate of asymptomicity might be, it would have been a good idea to run the model multiple times with different figures and see what you got, and see if it made a big difference. Another thing that's related to that is they had to make an assumption about whether or not there was a difference between the probability of someone, or not the probability, the probability that someone who is asymptomatic is more or less infectious than someone who is symptomatic. So the assumption saying, if you have symptoms, you cough, you sneeze, whatever, you're more likely to pass it on. Well, that sounds like a reasonable assumption in qualitatively, but quantitatively, they just had to pick a number, and I think the number they picked was about 50%. But people who were asymptomatic would be 50% less likely to pass it on, I believe. And again, that's a 100% guess on their part. They don't offer any evidence to support it. And again, sensitivity analysis would have been really helpful on that question, I feel. So let's talk about the results that they got with their model. The model was used to present three classes of scenarios. So that is, say, three different general broadly categorized approaches you could use to attempting to handle the pandemic. And they classified these in their terms as mitigation and suppression, and they didn't actually generate a term for the third one, but I'm referring to it as adaptively triggered suppression. And we'll go through those three one at a time. So mitigation, they looked at various combinations of school closures, social distancing, so that's effectively what we think of as lockdown, people staying at home, not being able to see other people, only being able to leave for very specific reasons. Case isolation, that's what we think of when we talk about people, that's what we talk about when we talk about people staying at home and staying off work and literally going out for no reason when they've got the virus. And house quarantine, which is, of course, people staying at home if they live with someone who they think's had the virus. And they looked at a window of 3 to 4 months because most of these interventions were considered to be in place for 3 months, but some, particularly socially distancing for the elderly, was considered for a 4-month period. And what they found was, of the most effective mitigation strategies, the one that they simulated that had the best results was 4 months of social distancing for over 70s combined with case isolation and household quarantine, so not even closing schools. And that was predicted to prevent 50% of deaths. All of these scenarios would, however, have involved the total capacity of the intensive care units in the country being greatly exceeded. which would not have been good, and of course would have inflated the death rates, one would imagine. Um, and again, it's really quite interesting to notice that school closures um, would actually have made the aforementioned strategy worse, which I find very interesting. Um, and I'm still trying to get my head around on some level. I'm guessing it has something to do with some sort of second spike afterwards, was my initial guess. I'm no longer quite so sure about that. I think that option may not have been graphed on the diagram, so it's quite hard to tell. But that's an interesting point. The school closures would actually have made it in some sense worse in mitigation. In regards to the first suppression strategy, they looked at suppression involving all age social distancing, so that's people of all ages social distancing, enforced for like 5 months, with case isolation more generally, which is of course people staying at home as previously described, and optionally either with school closures or household quarantine. So the interesting thing about this is that all of the options indicated a large second wave would occur after the 5 month period was up. So after the lockdown had ended in 5 months, there was always a second wave. And that second wave, well, the more successful the suppression, the worse the second wave. And they didn't actually present tabulated results of the number of deaths. And I'm assuming that that is because, realistically speaking, there was no likelihood of this strategy being used, possibly because actually there was very little benefit from it because of the huge extra second wave, and particularly in the event that the second wave is worse by a more successful lockdown. And that is the interesting thing. The more successful the lockdown, the more aggressive the comeback afterwards. The more successful the suppression during the lockdown, the larger and sharper the second wave. And that probably means that there was such a poor result from this simulation that they just didn't bother presenting the data. They just presented the graphs to illustrate why this approach wouldn't work. And so they came up with their third scenario, which was adaptively triggered suppression, as I'm referring to it. And that involves social distancing, much as before, optionally with school closures, but only to be turned on when the number of corona cases in ICU reaches a certain trigger threshold, and to be turned off when the number of corona cases in ICUs drops below a certain release threshold. And so the notion is you would kind of implement the lockdown in response to indications that you were on the upswing, and you'd have to do this repeatedly over and over and over again. And optionally, you combine that with, well, not optionally, it's assumed that that's combined with case isolation and potentially also household quarantine, but they're assumed to be applied throughout the entire period because there's no need to trigger or untrigger them. So yes, they only examine the impact over a 2 year period though, and that's quite telling and quite interesting because at the end of that 2 year period, they don't say what happens if you simply stop the lockdown. They don't say if you get a second wave. And if it might seem far-fetched to imagine you could have a second wave after lockdown, well, we're going to go through some maths about that later, and it's going to be a bit controversial maybe. But certainly they don't say how long you'd have to continue this periodic lockdown in order to prevent a second wave, or to get a decent minimization of deaths. They just report the number of deaths in the 2 year period and how it varies based upon the different policies. And that I think is quite misleading. Not saying it's deliberately misleading, but it is misleading insofar that it can lead you to think that these strategies are effective in the long term and that in and of themselves they can make a big difference. And really it's a question of, well, no, what it just tells you what going to be in 2 years' time in terms of what will have happened between now and then. It really doesn't tell you what position you're going to be in if you don't have any better options, any new tools. So the strategies involving school closure were included, in addition to social distancing, were predicted to keep ICU capacity from being exceeded in all but a few cases. So the really... Ooh. I was not expecting a text message right then. So yes, strategies involving school closure are predicted to keep ICU capacity from being exceeded in all but a few cases. These strategies involve the country spending 55 to 94% of the 2 years in lockdown. That was pretty typical, actually. And I think some of the mid-ranges was about, the mid-range was something like slightly more than 2/3 of the year in lockdown, 2/3 of the 2 years in lockdown. And that was the case presented in the graph associated with the tables. And yes, that's quite a long time for the country to be spending in lockdown to not know exactly what happens after that 2-year period is up. So yes, clarity on behaviour after 2 years, whether that is just a second wave or how long the policy must be continued to prevent a second wave. Well, we're going to get into that in more detail later. But clearly, the table is presented as if it gives you a sense of how effective a policy is in the long term, and the actuality is it really only tells you about how good it works as a delaying tactic in the short term. So, general comments about the report and my concerns about the report. Results are given in terms of deaths averted rather than years of life saved, or QALYs, a very technical term I'll explain in a moment. Quality adjusted years of life gained. So for various reasons, it's often more attractive and more helpful to look at health interventions in terms of the number of years of life that you have saved or lost as a result of an intervention. So conceptually, consider a heart transplant. There's a donor organ, and yes, it's to be given to someone, but there's two potential recipients. And one recipient is healthy and young, and the other recipient is either very old or quite unwell with another health condition unrelated to the heart condition. And a surgeon has to determine who to give the heart to. Well, understandably, they're going to give it to the person who's going to enjoy more years of life as a consequence of getting the heart. So you look at the number of years of life gained as a result of the intervention. And if you're making a comparison between two quite different effects, two quite different health effects that may not necessarily be happening at the same time. So obviously, if you have, tragically, someone dies and that person dies 10 years before their time because of the pandemic, that's tragic. And that is, I believe, the official estimation of the average numbers of years lost per death in the pandemic, 10 years. Whereas if you have some, tragically because of some mental health crisis, a young person commits suicide during the lockdown because they weren't able to access good mental health support, or indeed informal mental health support through their friends and family, then they might potentially be losing 60 years of life. And you could argue that in a sense that's a worse health outcome than 6 patients dying of the coronavirus. But of course it goes a bit beyond that, because there are deaths later on. You wouldn't necessarily know about the deaths right now. And see, non-pharmaceutical interventions, this is a second point, may have a very significant negative impact on health over the long time frame. We don't really know, but no attempt to quantify it's been presented in the paper. And there's this sense in which something that's done now could have effects for the next 100 years because we're deeply affecting people's lives. Some of the things that could happen now as a consequence of lockdown could be life-altering or life-ending in some dreadful cases. And these life-altering impacts could shorten people's lives. So someone might die prematurely by 10 years, 20 years, 30 years, but that death could be 30 years away, 40 years away, 60 years away. And so, in that sense, you can imagine the guy who tries to commit suicide and screws it up, or the individual who overdoses on drugs and they save his life, but his liver's severely damaged. And it's not difficult to imagine that they, in so many years' time, could be having a premature death as a consequence of something that might have only have happened because of the lockdown. And so there's no assessment of that impact, none at all. And I appreciate that's an incredibly difficult ask, but it is not beyond the realms of possibility to try. The model as it is presented, is not presented in full. There's no source code published, no pseudocode, no equations. In fairness, the type of model constructed isn't really amenable to being described purely in terms of equations. It couldn't be peer-reviewed. It couldn't be verified to operate correctly by an independent expert. If it was given to a paper, the paper would reject it. Not because the results are wrong, but because their veracity can't be tested independently. And that's something that we expect nowadays. And obviously it wasn't possible to get the paper peer-reviewed in the time frame concerned. That is absolutely true. But it's also been presented in a way that doesn't facilitate it being peer-reviewed retrospectively, which is not good. The model only examines strain on NHS capacity with regards to intensive care units. The impact of a pandemic on other areas of the NHS because of the lockdown, and also just because of the pandemic itself and because of the extra drain on the resources is not examined. We don't know what kind of impact, or certainly the model, the report does not present any data or predictions or assessment as to what kind of impact either the pandemic or the lockdown might have on other areas of the NHS, like emergency procedures, therapy, screening, acute mental health care, and by that I mean people, I largely mean people being sectioned, or people who need to be made inpatients, and that's not considered. That is not considered, which I consider problematic. So that brings us to the end of what we saw in the report up to now. I'm going to go through the rest of the report now. It's largely the discussion. I'm going to skim through it pretty quickly because I think we've covered all the important points. But just let them have their say, let them finish off what they have to say and what they are getting at. So, as the COVID-19 pandemic progresses, countries are increasingly implementing a broad range of responses. Our results demonstrate that it will be necessary to layer multiple interventions regardless of whether suppression or mitigation is the overarching policy goal. However, suppression will require the layering of more intensive and socially disruptive measures than mitigation. The choice of interventions ultimately depends on the relative feasibility of their implementation and their likely effectiveness in different social contexts. And feasibility, I don't know if that was their intention, but feasibility really should include whether or not the public will comply in the long term. Is that realistic? And whether or not the government can afford to support the public with the resources necessary for the period in question, and whether or not the drain on the welfare state because of potential unemployment is affordable in that lockdown period. and so on. These are all questions that really should have been considered. Anyway, and also enforceability. Disentangling the relative effectiveness of different interventions from the experience of countries to date is challenging because many have implemented multiple or all of these measures with varying degrees of success. Through the hospitalization of all cases, not just those requiring hospital care, China in effect initiated a form of case isolation, reducing onwards transmission from cases in the household and in other settings. Which is nice if you have tons of hospital space, isn't it? At the same time, by implementing population-wide social distancing, the opportunity for onward transmission in all locations rapidly reduced. Several studies have estimated that these interventions reduced R to below 1 in recent days. These measures have begun to be relaxed. Close monitoring of the situation in China in the coming weeks will therefore help to inform strategies in other countries. Overall, our results suggest that the population-wide social distancing applied to the population as a whole would have the largest impact,